The first message is that we have to evaluate whether the patient is candidate for an intensive therapy with a curative intention or is unfit for intensive chemotherapy. In the first case, we have to try to cure the patients with a frontline strategy and be as intensive as possible. And in most cases, around 65 to 70% of cases, we have to consider an allogeneic transplant in first remission, right? When these patients relapse, the outcome is very poor. If we consider that the patient is unfit for intensive therapy, then we have to take into account hematological improvement, the need for less transfusions, to get less complications that make the patient to be in the hospital, and also to maintain as longer as possible the quality of life. Then, anyhow, the outcome of relapse or progressing patients, relapse in the first type of therapy with in patients who achieve a complete remission, and progressing in patients who are not candidate for intensive therapy, but who get some hematological improvement, the outcome is very poor. And the long-term survival is just limited to those patients who were not transplanted in the first complete remission and are transplanted in the second complete remission. So in this case, we have about 30% long-term survival in relapsed patients who did not receive a transplant in first complete remission. As the situation is not good both for patients unfit as upfront treatment and for patients who relapse, the solution or what we are investigating are new agents. Basically, in combination with hypomethylating agents, and also based on the molecular targets and on antigenic targets. So we are referring to novel drugs that try to block what the aberrant pathophysiology of AML cells, or that target a surface antigen, and then they want to kill the leukemic cells through another way than conventional therapy. And of these new agents, we have new monoclonal antibodies against CD33, for example, against CD123. We have also it's being investigated the possibility of giving a checkpoint immune inhibitors, and we are in the beginning of the investigation of CAR T-cells for AML. Regarding molecularly target therapy, we have tyrosine kinase inhibitors, basically against FLT3 receptor, and we have many of them. First generation with sorafenib, with midostaurin, with quizartinib, and more recent ones as crenolanib and gilteritinib, for example. And but have also therapies that target p53, the nuclear export proteins, and many other targets.